بسم الله الرحمن الرحيم طلبتنا الأعزاء. Our practical session today is regarding oral pathology practical session. One of the commonest developmental abnormality or congenital abnormality of the neck is branchial cleft cyst. Characteristically, it is located as an anterolateral location in the neck or cervical anterolateral position. Usually, it is lined by stratified squamous epithelium or columnar epithelium. The cyst is thin-walled cyst filled with creamy secretions, and it is well demarcated and presented as a cervical swelling in adolescent life, usually. Branchial cleft cyst. Lymphoid tissue, mature lymphoid tissue, is seen within the wall, underlying the epithelium. And here the content, fluid content, serous or mucinous content, and necrotic debris within the lumen. Regarding benign tumors of the oral cavity, as you know, the lining epithelium, normal lining epithelium of the oral cavity is stratified squamous epithelium, and their corresponding benign tumor is called squamous cell papilloma. Squamous cell papilloma is presented or characterized by frond-like or papillary projections or finger-like projections made up of proliferating, thickened, benign keratinocytes or stratified squamous epithelium with excessive keratinization or keratin production. The core of these papillae is filled with stroma called fibrovascular core. Here there is a fibrovascular core, central fibrovascular core. Here the section in the upper part showing you cross sections in these papillae or these frond-like structures, and the lower part showing you longitudinal section. Again, papillary projection or finger-like projections made up of proliferating benign squamous cell epithelium with keratinization, and central fibrovascular core with intact basement membrane. No invasion of the basement membrane was detected because it is a benign lesion. Coilocytosis can be seen in higher power picture. Coilocytosis is a viral cytopathic effect caused by human papilloma virus infection. Coilocytosis, that is a perinuclear vacuoles or perinuclear halos. Regarding the premalignant oral lesion, premalignant lesions or precancerous lesions in the oral cavity, leukoplakia and erythroplakia, both of them are descriptive clinical terms rather than diagnostic terms. Leukoplakia can be benign, can be malignant, can be premalignant lesions, leukoplakia and erythroplakia. Both of them are descriptive rather than diagnostic terms, can be presented as whitish, irregular, thickened, roughened plaque within the oral cavity, below the tongue, sublingual, or in the buccal mucosa, or in the lining mucosa of the lips, or in the behind the molar teeth, or and so on, the hard palate, and so on. Erythroplakia, when there are red velvety foci of thickening, are associated with bleeding. Leukoplakia, in contrast, and erythroplakia are in contrast to oral candidiasis or oral fungal infection. They cannot be rubbed off. So regular, ill-defined mucosal thickening, whitish in color, with different areas of thickening. This excessive thickening and related to hyperkeratosis, and microscopically different stages of dysplastic changes can be identified, even carcinoma in situ and foci of invasive squamous cell carcinoma. Diagnosis and follow-up is important, and to ensure that there is no malignant spots, or any biopsy should be taken from any suspicious area to exclude malignancy and invasive cancer. So mild, moderate, and severe dysplasia, carcinoma in situ, and even invasive cancer can be detected in areas of leukoplakia. Squamous cell carcinoma or oral cancer, presented as oral mass or feeling of discomfort within the mouth, or unfitted denture, or dislocation of a tooth, or bleeding, or unhealed sore within the mouth. So irregularity and hardness and bleeding foci are features of cancer. Another picture showing you squamous cell carcinoma of the tongue. Here, ill-defined large mass in the lateral border of the tongue, showing central necrosis and bleeding, and fixed margin or base related to invasion of downward muscle and even to underlying bone, mandible. Here, squamous cell carcinoma of the floor of the mouth, irregular hemorrhagic necrotic surface, infiltrative borders, and with associated areas of necrosis, can also invade the underlying mandible, necessitate resection or partial resection of the mandible. Squamous cell carcinoma of the oral cavity in 45% of the cases involving the lips, and 90% of the lip involvement occurs in the lower lip rather than the upper lip. Here in the lower lip, there is an irregular, ill-defined, ugly-looking mass or lesion involving the lower lip with areas of change in the color. Here there is discoloration, deep discoloration, areas of bleeding and necrosis, and also thickening due to fixation to the underlying muscle. Another picture showing you lateral lingual mass or nodule, irregular thickened hyperkeratotic foci of whitish discoloration indicate hyperkeratosis, and foci of bleeding due to repeated trauma with the mouth, and feeling of discomfort, pain, and unhealed sore or nodule with ugly looking shape, infiltrative margin, hardness, and bleeding and necrosis. Squamous cell carcinoma is the classical feature of oral cancer. It can be presented as well, moderately and poorly differentiated. Differentiation is the degree of similarity of the tissue of the tumor to the tissue of origin, is the degree of similarity of the tumor to the tissue of origin. Here in squamous cell epithelium, the feature of well differentiation is the keratin pearl or keratin eddies production of, as in this picture, concentric lamellated hypocellular material, eosinophilic extracellular material is a feature of well-differentiated squamous cell carcinoma, whereas the other feature of differentiation, which is in moderately differentiated carcinoma, is the presence of intercellular bridges, hair-like structures, delicate hair-like structures, or called desmosomes, connecting each adjacent cells. Hair-like intercellular bridges is a feature of moderately differentiated squamous cell carcinoma without extracellular keratin production. Active mitosis, pleomorphism are another features of malignancy, whereas the poorly differentiated tumor, the cells the poorly differentiated tumor lose their features of differentiation, including keratin pearl production, and intercellular bridges or desmosomes are lost here, with the frank or severe atypia, pleomorphism, hyperchromasia, coarsely clumped chromatin, and a very important feature of malignancy is atypical mitosis or aberrant mitosis. That is quadripolar or tripolar mitosis that occurs only in malignant cells. This type of mitosis never happens in normal cells. It is called sine qua non of malignancy. So well-differentiated, moderately differentiated, and poorly differentiated squamous cell carcinoma. Salivary gland lesions or disorders of salivary gland, they are present, as we say previously, as three major paired organ, parotid, submandibular, and sublingual, with other small minor salivary gland distributed throughout the oral cavity. So the parotid gland composed mainly of serous acini or glands secreting amylase and trypsin and chymotrypsin to digest carbohydrate within the mouth, to start or initiate carbohydrate digestion within the mouth. These are the excretory ducts lined by cuboidal epithelium, and lobules of mature adipose tissue are normally present within the parotid parenchyma. Submandibular gland is mixed salivary gland, mixed, both serous and mucinous component can be seen within the gland, in addition to the excretory or collecting ducts. Sublingual gland are mainly made of mucinous acini or glands, no serous acini, and this is a picture with dilated ducts filled with thickened secretion and calcified secretion result in stone formation, intraductal stone formation within the dilated duct with secretion and chronic sialadenitis. Sialadenitis is inflammation of the of salivary gland tissue, sialadenitis, whereas sialolithiasis or sialolithiasis is the formation of stone. Lithiasis is stone formation, as in cholelithiasis, that is the gallbladder stone. Here, sialolithiasis, which is indicate or necessitate surgical removal of the stone to restore the passage of fluid and to remove the obstruction. It is a complication of chronic sialadenitis, whether autoimmune, whether pyogenic, and so on. Regarding tumors of salivary gland, they are divided into benign and malignant tumors. The most common benign tumor of salivary gland is, especially the parotid gland, is pleomorphic adenoma. Up to 70 to 80% of parotid gland tumors is made up of pleomorphic pleomorphic adenoma. Radiological imaging is important to demonstrate the well demarcation and intact border of the tumor surrounded by a rim of non-tumorous parotid parenchyma, cervical swelling or pre-auricular swelling. The cut section or the gross cut section of the neoplasm is made up of solid, well-defined cut section tumor growth with the glassy or chondromyxoid chondromyxoid cut section. It is called glassy or translucent or chondroid and so on. Important feature is the well demarcation, and no features of invasion can be seen surrounding the gland, and still there is a little area of uninvolved parenchyma. Strong attachment or adherence of the tumor to the underlying soft tissue can be responsible for the increased rate of recurrence after tumor resection. So good resection margin, surgical resection margin or wide surgical resection margin is important during the operation to reduce the rate of local recurrence. However, the tumor is benign and no invasion, and the rate of malignancy is very rare, less than 1% after many years. Another gross cut section demonstrates the well-defined margins and adherence to the intimate adherence of the tumor to the underlying soft tissue. That is why the good resection and wide resection margin is important to reduce the rate of recurrence. Again, solid and glassy, even with mature cartilage formation, can be seen in the cut section of pleomorphic adenoma. Pleomorphic adenoma, another picture, areas of bleeding here, foci of vascularity within the tumor sometimes, and the main cut section is made up of chondromyxoid stromal element. Microscopically, the tumor, this is the fibrous capsule or pseudocapsule, and made by the soft tissue or by the body, and here a rim of normal surrounding parotid parenchyma. As we say, benign tumor grows by expansion and malignant tumor grows by infiltration. Here, the tumor made up of proliferating epithelial and myoepithelial acini and cells arranged in acini, cords, trabeculae, islets, and so on. Pleomorphic adenoma, the name is related to the origin of the tumor. It is multifocal or polyclonal. It is called polyclonal, mean the tumor is originated from many type of cells. Pleomorphic, many origins for the same in the same tumor. So epithelial cells of the acini, of the parotid acini, myoepithelial cells surrounding the duct, the excretory ducts, and the stromal elements including myxoid element, chondroid element, and even sometimes ossification with bone formation. So pleomorphic indicate multiple origin or multiple types of tumor cells within the same neoplasm. Again, pleomorphic adenoma, acini, trabeculae, single cells, and islets of epithelial and myoepithelial cells. All of these neoplastic cells are benign looking, bland looking, benign in nature without malignant features, and abundant surrounding chondromyxoid stroma, basophilic discoloration. Even mature hyaline cartilage can be seen, lacunae with the surrounding cartilaginous stroma and hyalinized areas. In addition to these islets and nests of neoplastic epithelial and myoepithelial cells. This is typical picture of pleomorphic adenoma. Pleomorphic: epithelial, stromal, myoepithelial, cartilage, myxoid stroma, and so on. The second most common tumor of salivary gland, of the parotid gland, almost always, is called Warthin tumor or papillary cyst adenoma lymphomatosum. The tumor is cystic in nature, so one of the most important differential diagnoses of parotid cystic lesions or structures, in addition to congenital anomalies, cystic dilatation of the duct, and so on, is Warthin tumor, papillary cyst adenoma lymphomatosum. The tumor is made up of cystic structure lined by papillae or papillary projections, covered by bilayer of oncocytes with underlying mature lymphoid tissue element. Clinically, the tumor is associated with smoking. There is increased incidence in smoker men, 8 times than non-smokers. Cystic nature, in contrast to the solid quality or solid cut section of pleomorphic adenoma, and slight female predominance in pleomorphic adenoma, whereas here almost always in male with increased incidence in smokers. Adult male. Warthin tumor, radiological or ultrasound finding is cystic, definite cystic structure, or indicates cystic structure that is translucency with internal content or thickened fluid content. Warthin tumor. Fine needle aspiration cytology from the mass or from the cyst. We can aspirate cellular elements, sheets of cohesive epithelial cells with large, abundant granular, eosinophilic granular cytoplasm, vesicular nuclei, and prominent nucleoli. All of these cells are benign. No features of malignancy can be detected. Fine needle aspiration gives us a hint, or we can pick up a Warthin tumor by fine needle aspiration cytology. This is the cut section, or this is the microscopical appearance of Warthin tumor. The tumor is cystic in nature. This is the cavity of the cyst, and the cyst is filled with many papillary structures and with central core of mature lymphoid tissue, and covered by bilayer of oncocytes. A higher power showed you the papillae, the true papillary structures, and the cystic nature. This is the lumen of the cyst, and this is the serous fluid within the cyst. And here the projecting multiple papillae covered by bilayer of oncocytes, epithelial cells, or called Hertel cells, with underlying or central mature lymphoid tissue element. Higher power, showing you also the bilayer covering or lining of these papillae, oncocytes, large cells, abundant with abundant cytoplasm with eosinophilic granularity, and vesicular nuclei, prominent nucleoli with internal mature lymphoid tissue element, and hence the misnomer of lymphoma. So it is not lymphoma, it is reactive lymphoid tissue, even as if we are in a reactive lymph node, even central germinal center, or can be seen within the core of this papillae with mantle zone, as if we are in a lymph node tissue. Benign. Second, this is Warthin tumor. This is the second most common benign tumor of parotid. The commonest malignant salivary gland tumor. There are many malignant tumors of salivary gland, but the most common one is called mucoepidermoid carcinoma. Mucoepidermoid carcinoma. Features of malignancy. Gross features of malignancy can be summarized as hardness, solid cut section, infiltrative margins. Here the margin is infiltrative, ill-defined margin, attachment to the underlying soft tissue and even bone, and infiltration, not expansion of the borders. Microscopical appearance. Is common. All features of malignancy can be seen here. Pleomorphism, you can identify pleomorphic cells. Each cell have its different shape and size and nuclear size. Irregular nuclear membrane. The nuclear membrane has spikes or has notches, and frequent mitosis is a mitotic figure, mitotic activity, frequent or brisk mitotic activity. Pleomorphism is very prominent and multiple nucleoli, in addition to the bi-quality or double quality or double cell population, that is the squamous epithelium and clear cells or mucin secreting cells. So it is called mucoepidermoid carcinoma. The incidence of malignancy in the minor salivary gland is higher than the incidence of malignancy in the major salivary glands. Another malignant tumors, also adenoid cystic actinic cell carcinoma, squamous cell carcinoma, also can be seen in the salivary gland, but in a lesser extent. Thank you.